Welcome to the first primetime debate dedicated to innovations in patient treatment planning and communication. To skillfully lead us through this session, I'm proud to be joined by the chairs of this session, Florian Beuer and Chmielewski. Welcome, gentlemen.
Thank you.
Can you introduce us into the topic of today and our speakers?
For sure, today we will talk, especially in this part, about innovations and communication with the patient. So it is very interesting and important topic, and we are really excited just to hear the opinion from our experts.
And we have two fantastic experts starting with this session, Pablo Ramirez and José Navarro, and they will talk about innovation and technology for patient treatment, planning, and communication. So we're looking forward to your lecture, so the stage is all yours.
Thank you. And while you guys walk over to the stage, let me remind you that we are live as well. So if you have questions for our speakers, you can actually pick up your mobile phone, surf with to the mobile website app.eao.org, and you can send in your live questions for the discussion at the end. And if that's too difficult to remember, look at the back of the leaflet, scan the QR code, and click on the button Interaction. Pablo, José, when you're ready, take it away.
Thank you very much, Mr. Chairman, Gerrit. It's a great honor and a pleasure to be in front of such a distinguished audience today with my colleague and dear friend Pablo to try and share with you how it is that we have implemented technology and innovation in our daily practice in order to communicate with our patients and in order to do our treatment plans. There is no doubt that when Pablo's grandfather was being overlooked by Pablo's father in this image in the last century, and they were talking about communicating and treatment planning, things were not quite how they are today. And that is not just because they're not wearing masks and gloves, but the reality is that today we stand in front of treatments that we try and bring in an interdisciplinary approach where the different specialties meet to try and diagnose to the best of our ability, utilizing all the knowledge that we have in the different fields and using the available technology that is readily available to us in order to do our treatment plans, in order to communicate within each other, in order to communicate also with our patients. There's no doubt for us today that if we want predictable treatments, which is our ultimate goal, we have to work very hard on our planning phases. Planning and communicating is really the most important factor for any plan that for any treatment that we're going to embark. And through planning and communication with our team, with the different specialists, with the patient, with the lab, we are then able to provide a guided dentistry approach where we basically set up a plan that we follow from beginning and all the way till the end of our treatment, making guided dentistry possible through implementing all of this planning and communication all along the way. Now, if you look at this book that I was able to edit with my dear friend Jonathan Franks and Nelson Silva in 2013, the chapters that eluded digital workflow very soon came outdated. And this is quite normal in the day-to-day running of our dental world. Things that are true today soon become taken over by other technology that we have to very fast implement. There's no doubt that today, digital scanning, treatment planning, three-dimensional imaging, printing are all changing the way we practice dentistry. Bear in mind that these techniques are adopted by us, professionals, to try and become more predictable, more efficient, and more effective with our treatments. We try to reduce adverse outcomes by utilizing these technologies. Now, we have to bear in mind and we have to understand that these digital tools are only here as an adjunct to our professional expertise. So we have to bear in mind that it's still us guiding the treatments, no matter if we're using the technologies or not. Now, technology and clinical innovation has changed very much in all of the fields. And
as we can see, all the fields have been changed with this clinical digital revolution that we are living right now. If we look a specialty for each one, we can see, for example, in the restorative world, we are moving more into highly static demanding cases in a full digital workflow. And this is because we understand much better the way that we are scanning. We understand much better also, that is very important, we will see later on, the software that we are using to manage all this information. On the other hand, the restorative side is always very well and much connected with the lab side. The lab side has a very important part in this digital revolution, because we are giving now much more information for them. We are facially driven our treatment plans, and we are using these digital libraries to have these natural algorithms that at the end of the journey is that we want to copy, if possible, in the monolithic ceramics that we are using more and more in our daily practice with good success and high aesthetics. If we check a little bit into the ortho world that is living a revolution, we have three things that have been very well implemented, and now we're happy to have them on board. Finally, we have the face. This is something that we much needed in our treatment plans, because we were moving teeth without having any reference in the 3D world, and now having the face, we feel much more comfortable sharing the information with our orthodontists and with our team. Secondly, we have also the CBCT information, very important, because now we are treating more adult patients. We can really have a much better control of the movements, and we can see the bone defects, and we can really customize the ortho for the patients. And the third part, since now we are doing a lot of much more interdisciplinary treatments, we can combine the tooth movement and also having the restorative information. This will help us to be less invasive and, again, have a much better communication with our team and with our technician.
When we look at the more surgical aspects of dentistry in the perio field, we're also able to superimpose our STL images to our DICOM files, to our facial photographs, and we are able to really measure to a very good degree of accuracy exactly where our tooth structures are, where the bone is, where the soft tissues are. We can work around planning, that important planning phase that then allows us to create the guides that we might need to be able to then remove the adequate amount of soft tissue or remodel the bone to the extent that we will want. Always trying to follow the same protocol, no matter the discipline, guided dentistry, where planning is followed by the execution of treatment from A to C, all along the way of the treatment. When we look at implant dentistry in a very similar way, we diagnose our patients utilizing facially driven treatment plans. We're able to superimpose, utilizing adequate software, the different STL files to the different DICOM files, to then be able to design in this virtual world, in these softwares, the way that we're going to be creating and generating our different guides for the procedure, our provisional restorations, and ultimate even our final restorations. We do our planning before we start, just like we would plan our house before the architect actually starts building it, and then we follow stage by stage in a copy and paste type dentistry, utilizing the same files that we use since the very beginning towards the final treatment at the very end of it. Now, one important aspect of this is that the way we focus our treatment planning and our evolution of our treatments, we're actually diminishing a lot the execution time, meaning that we're spending a lot more time, and this is throughout the disciplines, in the planning phases, in the actual treatment planning and the communication, and then a lot less chair time is often needed to actually generate and deliver the procedures. Patient treatment planning and communication, which is really the main focus of our topic today, has definitely changed the way that we practice on a day-to-day basis. The patients start to interact with us way before they come to our clinic through social media, through the online platform, or just by our secretaries who pick up the phone in aim of giving them an appointment. And from that moment on, we cater not only to the highest finesse of dental work that we can, but also giving the patient an adequate experience in the dental clinic. It's important to understand the digital steps that actually make this so-called virtual patient. And we're always going to be following the same type of protocol where we're going to acquire our data first, utilizing videos, utilizing photographs, then taking CBCT scans to acquire those DICOM files, taking intraoral scans to acquire those STL files, facial scanners, virtual articulators. We acquire all that data in different techniques. For example, we have a small studio in the clinic to take our photographs, today pretty much done by our helpers in the clinic, but they follow the same protocol, taking CBCT scans again in most of our cases, and then going ahead to the intraoral scanning phase. Now, if we look at our own work here at the EAO with this Delphi study, the experts that analyzed and reported, they actually understood that by the year 2030, 80% of the experts said that we would need three-dimensional imaging for appropriate pre-surgical implant planning. So we ourselves are recommending that obviously this is the way to go. Cone beam CT technology has had an exponential growth in the last decades, and the reality is that it still continues to grow into our daily field. In a similar way, if we look at our Delphi study again from the EAO, you can see that when we ask the experts what will be the preferred method for impressions, the answer was quite unanimously 90% of the experts said that by the year 2030, we would be using fully intraoral type of impression protocols. And only 10% said that we would be using the type of hybrid ways that we are in fact mostly using right now. And again, similarly to our CBCT market, the intraoral scanning market has had an exponential growth and continues to grow as it gets implemented into the different clinics around the world.
So we really have to understand, I think, to switch our minds, that intraoral scanners are not only the substitutes of the regular analog impressions. Nowadays, and besides that the intraoral scan started in the early 80s with Dr. Bormann and the FEREC machines, nowadays we understand that we have much more possibilities with these machines in our office besides the restorative or the execution part. Of course, we are using, since we are scanning every patient, every visit, to have a much better programs of preventions and diagnose with our patients, because we have a much better control of the status of the oral health. We can, again, communicate much better. We can also diagnose possible interproximal decay. So all this information we are acquiring every time the patients come to our office. So we have more data to analyze and, again, to communicate with our patients. We also use this technology for surgical procedures. We want to also monitorize our surgeries and, again, communicate to our patients. In this case, for example, we did some grafting after ortho treatment, so we want to monitorize and double-check how the root coverage has gone, if we have some recessions, and also we will, again, scan the patient probably after 6-8 months to have a much better control and to be sure that we don't have any problem, and if something appears, we are ready to treat the problem. We are also using time-lapse control for different situations. This is classic now in our protocols in the office. We can explain to the patient if they have some wear problems, some fractures. We can really show them. The patients, they want to see. They don't want to sit in the chair and just to see us explaining the situations. If they can see with the tools that we have now, with intraoral scannings, will be much better. Of course, we have static analysis with the same programs, occlusograms. We can show them, for example, like in this case, that maybe some ortho will help to have a correct canine guidance. And at the end, also, with the ortho cases, we always like to monitorize. So every 6-8 months that the patients come to the office, we want to re-scan the patients, double-check, see that everything is fine, we don't have any relapse. And from there, we can continue to monitorize with the prevention and the normal hygiene with our patients. Continuing with the data acquisition of the patients, and we saw in the lectures before, we have different things available in the market. Even though it's something that we are not using regularly in the daily practice, we truly believe that in the near future, we will have devices that we will use it on a daily basis. We can have like static or dynamic solutions. The problems that we saw or we had is that it was difficult to align the face with the intraoral scan. So that's why also groups with Marta Revilla and her team, they are showing us that the best way to do it is normally we having some scan bodies that are helping us to incorporate all this information. But also, very important to understand that operator makes a very important situation here. So we really need to have a control of the whole situation and understanding that this technology will probably be integrated in our daily workflows pretty much soon. The last part, to have the virtual patient also, is the 4D virtual acquisition. And this is also very important. We are not using also regularly in our daily practice, but we truly believe that we will in the near future. What we have seen when we tried all this technology is that it's giving us a lot of information. We see the patient in motion, we see biting, guidance, and everything. But we really need, after having all this information, to analyze and to understand what it means. And after that, we have to share this information to the lab technician that also has to incorporate all this information to then after produce the devices or the restorations or the splints or whatever the patient needs. But before acquiring all this information, we really need to understand how to manage the information that we have already acquired.
So basically, we are talking about a physical world and a virtual world. We acquire all that data through cameras, through intraoral scan, through cone beam CTs, facial scans, dynamic articulators, and we're working in that physical world. Then we have to go into the virtual world to start working with our softwares that are able to communicate the different languages that all of our different capture systems actually speak, so that we can then design whether you outsource or you do it on your own clinic or whether you do a mix of both. This process has to happen so that we can then send all this information to the manufacturing side, so that we can then start milling or printing, sintering, whatever we have decided that we need for the patient, whether these are guides to do the procedure, whether these are provisionals, whether these are final restorations in the case we decide to do so. So basically, we're going from the physical to the virtual to then the physical world again. And in all of our cases, no matter what specialties are involved, we always try to follow this same type of protocol. We acquire all of the data that we need, the way we've shown you before. When we have all this data, we implement artificial intelligence, natural algorithms to allow us to decide what type of restorations, what type of shapes or forms we're going to be wanting for our cases. We then go ahead and start producing our guides if they're needed, to produce our provisionals when we need them, our mock-ups through model when we print them. And after we've done all of that is when we're really going to go ahead and anesthetize our patient for the first time to start our procedure, if that is what's needed. So at that moment, we have guided preparation, guides to do our preparations, guides to place our implants, guides to do our perio procedures when they're needed too. And it comes to a point that we can then decide whether we want to continue digitally in our treatment or we want to go and proceed in a more analogic way. And the reality is that there's no right or wrong here. There are possibilities that we just have to master and master with our technicians so that we can provide and deliver the most predictable outcomes, no matter if you're going through a digital phase or you're going through an analogic phase. But again, the most important factor out of all of this is that through our planning phases, through our communicative approach within the team, within the staff, within the members of the whole team, lab, as well as the patient, we're spending a lot of our time planning this type of procedures, planning this type of long treatments, and then spending much less time in the execution part of the phase. Now, we have to understand that all of these techniques are in need of these softwares that allow us to communicate with all the data that we've acquired. And today we have multiple different platforms that allow us to integrate all of this information and communicate this information to one another. We have lab softwares, we have dental chair side softwares, we have softwares that are specifically to communicate with patients, we have softwares that are online or free, and others that are super expensive and complicated, and we will need to see who is going to be driving the seat of that planning. Typically speaking, in our case, we share that with planning experts and at the same time our laboratory technicians, but always guiding these procedures ourselves. Now, in this type of softwares, as you all know, we can implement the different layers of things and have our STL files and have our DICOM files and have even our facial scans or photographs to be able to extract teeth before we've actually done it in real life, to be able to see where it is that we want to place our implants or our prosthetic restorations in base to that patient's face. We're able to analyze in detail our facially driven treatment plannings already from a very early stage, before we even get the anesthetic in our hand, as I keep saying. We plan everything from the beginning and then just have a route plan that we have to follow throughout, step by step, doing what we call that copy and paste dentistry, where we're planning and then following with that same project all along throughout the different stages.
So one of the biggest changes, and Andrea will show us later, is the incorporation of the digital wax-ups. We truly believe that this has really changed our digital workflows. First of all, again, we have the face of the patient, so we can integrate the face to all this information. Secondly, we have all these natural algorithms. We have a lot of libraries that we can use, and at the same time, if we have the correct timing and we have the knowledge ourselves, but also in the restorative cases with our lab technician, we are able to do, again, copy and paste dentistry. We can follow the plan from the initial communication with the patient through the mock-up, provisional, and then the final restoration. So this is what we really want. We want to have the clinical skills, knowledge, and training, and of course, respecting the biology, but we want to match after the ideal plan with the clinical side. So in this time, we will be ordered again, be ready to deliver the final restorations. Like in this case, we're using monolithic restorations more and more in our daily practice, trying to do this copy and paste dentistry and copying the nature, but understanding all the protocols, also very important from the lab side in terms of staining and glaze. So 3D printing is changing already our world, and especially in dentistry also. The good thing about it is that we have different options. We have from desktop solutions through more advanced and more expensive machines. But the good thing about this is that it's evolving very fast. And it's evolving not only the machine itself, the resins are evolving very fast, and we are using them also as a communication tool again with our patient. We are sometimes outsourcing the designs, and then we are in-house printing, like in this case, these small temporary veneers, to be ready and to be sure that the patients really like. We take some videos, we take some pictures, and at the end we compare if we like it or not to make the final decisions and to have the final restorations.
Similarly, in the implant-related cases, we are able to, utilizing the same printing technology, we're able to test drive in our patients our prostheses in a way that we weren't able to do with such ease before. And at this time, we're able to stain and glaze if we would like. We're able to add some pink tissue if we would like to make it all look better in the mouth. We bring this to our patient's face, and at this point we can go ahead and not only decide whether it is aesthetically pleasing or not, but we can also check the occlusion and check the speech and check what the patient is really feeling with this type of restorations. And it will be only at this point that we'll scan again that bite and send it to our lab for the fabrication of the final restoration. Again, 3D printing is growing exponentially and very, very fast, penetrating our market for more and more of the procedures we do. As Pablo said, the materials are increasing at a very, very fast rate. Lastly, we'd like to share with you the fact that artificial intelligence is really taking over everything we do. Whether we're going to work and we use Google Maps or Waze to find the fastest route, whether we're going up to Skyscanner to check our flights, we're being sent information that has been really learned through machine learning, deep learning, and we're getting that output to solve a lot of the problems that we have today. Today we have technologies that allow us to give us a second opinion, as the software in this particular case is called, where you have artificial intelligence telling you where it is that you can find decay, where it is that you have calculus, where it is that you see bone loss, and you know, not that this is what we have to follow, but it is a second opinion over your shoulder telling you and also communicating to your patient to really figure out whether there's something you've missed or not. And I say missed or not because as dentists, we're not perfect. And if you look at different studies, you can see that in a case like here, 136 dentists that looked at full mouth series of x-rays, when you look at one particular upper molar, 51.5% said that there was decay on the molar, and 48.5% said that there was not. Imagine being on the patient side here. What is really happening? And now we have AI that's going to tap our shoulder and kind of like raise the level of the dental work that we're doing, because it's going to wake us up, especially those that are not practicing very good dentistry, to be able to make our procedures better and better. Now, to conclude, and as I have, or we have 1 minute left, I'd like to share with you basically a resume of what we've discussed. New technologies and innovations are definitely changing the way that we practice dentistry. We believe that communications through technology helps a great deal to plan our cases more accurately, more precisely, more effectively. These digital tools are adjuncts to the specialist expertise. This is very important to understand. They're not going to, for now, supplement our own knowledge. Most time, right now, in our day-to-day practices is spent in that planning, in that communicative phase, and less time in the execution. We believe, and we're pretty sure about this, that big data will continue to grow. Artificial intelligence will continue to expand to help us and aid us make decisions through processes that are today unheard of. Thank you very much.
Thank you very much, Pablo Ramirez and José Manuel Navarro. Impressive talk, impressive kickoff of this session. Here's Florian.
Yeah, it was
What
a
we're gonna
perfect
do
start,
next.
I think. And our next speaker will be Rino Burkhardt from Switzerland.
And the question is there any evidence which can support effectiveness of communication with our patients? And I think this lecture will address this issue.
Rino, take it away.
So, ladies and gentlemen, dear colleagues, I welcome you to the next lecture within this afternoon session of this year's EAO Congress. The title and the topic that was given to me from the organizing committee is Evidence on the Importance and Effectiveness of Patient Communication, combined with the questions, how do we gain trust? You know, personally, I am convinced that patient communication and the trust that we receive from the patient is of utmost importance for the outcome and for the patient happiness. And maybe this was the reason why I was invited this afternoon. But honestly, it gave me a bit of a problem, because how shall I pack my personal beliefs into a session that should be evidence-based on innovations in patient treatment planning? I have at home a couple of articles, but I wanted to give the needed pinch of evidence, and of course also to get an overview of what is available related to knowledge. That's why I did a Medline search. The term patient communication gave me more than 200,000 results. When I combined it with effectiveness, still 70,000. And when I was using a filter for meta-analysis and systematic reviews, I still had almost 3,000 results. So you can imagine much more is investigated in this field than is done with zirconia crowns or graft harvesting from the palate. And you also realize that it's very difficult to select the relevant information and to condense it and, let's say, progress it into a meaningful concept that can be presented within just 20 minutes to you. Now, very often in our courses, we discuss what makes a good clinician. And you know, there is for sure more than one modality that is needed to assess something so complicated or complex, like delivering health services from one person to another. But very often we get as an answer, it's for sure knowledge as the key for success and good hands. But it's more complex, because knowledge, usually we think it's factual knowledge, health literacy, but knowledge as an endpoint does not serve anything. We have to need knowledge to do something, to take decisions, or to act. Or for example, knowledge can be subclassified in different types. Only tacit knowledge, you might not know, but tacit knowledge is very well investigated in the research of expertise in chess players, in music performers, or for example in sports. It is, let's say, it reflects the ability of a person to act in a given context, enabled by the implicit interaction with the environment. Also, technical skills cannot be seen isolated. They have to be seen in the close connection with a human sensory, perceptual, and cognitive information processing system. 3 years ago, we published a study and we could show that in periodontal surgical skills training, visual ability have a much higher influence on the surgical performance than psychomotor abilities do. And there is something missing still. It's the huge area of the non-technical skills. These comprise the cognitive skills, for example, decision-making, how to deal with uncertainty, reasoning, or the interpersonal one, communication, teamwork, and leadership. When we discuss now about communication, we have also to scratch a bit on the specialty of decision-making and the cognitive biases. Now I come to the relationship between the doctor and the patients. According to behavioral scientists, one of the most complex interpersonal relationship that exists. It's pretty obvious that the lady on the right side needs a dental treatment. Maybe the lateral incisor has to be restored, so the clinician has to make a treatment plan. Literature data clearly show that today the main, let's say, base of taking decisions are experiences, personal one, the discussion with colleagues, and sometimes also emotions that a clinician has. The latest, since the introduction of evidence that became central in the turn of the millennium, central to research, to teaching, to writing, but also to practicing, we expect that our decisions should be based also on a sound evidence level. But in the last decades, more and more critical voices are raised. These voices complain or argue about the many interconnected organizations that have an influence on evidence. They complain, for example, about that the brand or the quality mark of evidence-based has been misappropriated by vested interests. They complain that, for example, evidence is mainly maybe influenced by management and technology-driven prompts rather than patient-centered. Or they complain that statistical outcome sometimes has nothing to do with clinical relevance. Or, for example, that there is an enormous amount of evidence. I read an article some time ago, and there was written that in 2020, in biomedical research, there were published more than 100 trials per year and several dozens of systematic reviews per day. So the new article indexed in Medline per year are more than 800,000. This makes us understanding that the question how we will ever keep up with this enormous amount of information. Back to the relationship between the doctor and the patient. This relationship is clear or characterized very often that there is a gap between what the doctor knows and what is done at the end. So with the model of the evidence pipeline, we can very well show what happens with this evidence. First, is the doctor aware? Is that he accepts the evidence, or is he able to apply in his environment the evidence? There is a nice study from the Netherlands that had two objectives. The first was to evaluate the implementation of clinical practice guide for wisdom tooth extractions and to measure its impact on the changes in the knowledge of the clinician. And secondly, on the changes of the referral rates. The evaluation was a randomized clinical trial, and the intervention group got detailed information, which could be shown that the intervention group had much better knowledge at the end of the period. Surprisingly, it had no impact on the referral rates. So they concluded that these practical guidelines and teaching improved the dentist's knowledge, but had no effect on decision-making. Then we have to be able and act on the evidence. Also a study by Gallagher, he took 210 clinicians. All of them had to be experts, and they had to perform a simple simulator task. 15 surgeons had to be excluded as they were not able to at all complete the task, and 10% were performing up to 20 standard deviations from the mean. So this showed the huge variability, especially in technically sensitive procedures, and also asked the questions, what are the bases of defining technical expertise? And also require to establish metrics that make these evaluations transparent and fair. You know, only when evidence arises, the fifth step, we can have a clinical quality improvement. But there is also a high risk when you apply your evidence that you run into an error, namely when you apply the evidence on the wrong patient. There is also something else. A substantial amount of evidence requires the participation of the patients, especially preventive measures. So here we need a patient, otherwise the evidence is for nothing. The patient has to agree and has to adhere to. Adhere to means the patient has to exercise more, to eat less, to quit smoking, or to improve cleaning, which sometimes is very difficult. Now to have in mind the title question and the importance of the evidence, and also the importance of the communication, I would like to show you a study to share with you. This was a study, a survey, including 3,000 patients. And the goal of the study was to ask them about their subjective perception, how well informed they are. I can summarize. 1/3 felt extremely well informed, 1/3 was a bit less, and the other third was not at all informed. The conclusion said that Black people were significantly more likely to feel well informed. The study was done in Michigan, in the University in Ann Arbor. Lower education and lower income was associated with feeling extremely well informed. And now feeling extremely well informed was associated with complete trust in the care provider. And complete trust was correlated with a willingness to adopt elective surgeries. So at the end, this is answering the title questions. What we have to do is, we must feel the patient well informed. But what if the patient lives like this? The trust will not be sustainable on the long term. I will not keep away from you the second part or conclusion of this study. It showed that there was only a very slightly correlation between the knowledge scores, what the patient really knew, and their perceptions. Overall, there was absolutely no relation between the scores, what they knew, and the perception of being well informed. Means that participants had many gaps in understanding the benefits and harms, and also people are generally not able to assess what they really know. And this is not true for patients, sometimes also for clinicians. That means when I have to look at this through and through forcation lesion on the upper molar, when I'm a periodontist, I would maybe recommend a resective surgery. A more heroic one would go for a regenerative one. But if I would be, let's say, an oral surgeon that is very skillful in communication, the patient maybe would accept an extraction of the tooth. A smart prosthodontist could convince the patient to extract the tooth and make a bridge, and others would maybe remove it and place an implant. Exactly this has been done by Zitzmann and co-workers. They sent this to specialists and have shown that the preference is mainly based on other things than unbiased evidence. This is the so-called specialty bias. Since the works for Kahneman-Tversky, you might have heard about cognitive biases. Cognitive biases is inherent to all persons. They are strongly influenced by emotions and are processed unconsciously. Today we know a lot about the influence of the cognitive biases in diagnostic accuracy and also in treatment. Cognitive biases are hardwired. Hardwired means they compromise rational decision making. Hardwired, I can show you on the example of an optical illusion. I ask you which square is brighter, A or B? I would say B, but if you look at the bar, they have exactly the same color. This is what happens with cognitive errors. We also did a survey 5 years ago, and we asked people, what would you do here? You can make your vote yourself. We asked, preserve both implant teeth, remove implant, and preserve teeth, preserve implant, remove tooth, remove both, or I don't know. I will show you the results. Overall, 96% was taking a decision, and we did not want to show right or wrong. What we want to show is that the 96% were exposed to a bias. This is the so-called premature closure bias. That you at least see some clinical pictures. I quickly show you the case how I solved it. I was removing the implant. I built the flap, a palatal flap, a pedicle connective tissue from the gingival portion. Then I was cutting a piece of the end. I was splitting the part. One went over the root, the other to the buccal. And I fixed this little piece on the connective tissue, and the colleague was prosthetically restoring the tooth. There are for sure many other options. In the meantime, there are about 24 of cognitive errors described in the literature and their influence on clinical decision-making and performance. And there is also, a lot of these procedures have been encouraged by the huge successes of other high-risk industries, such as aviation, such as car racing, and many others. And aviation is just as safe because the non-technical aspects have been included in the evaluation. Recent data also show that the instruction and teaching of metacognitive skills have a huge potential to reduce the cognitive biases that we are exposed. We cannot eliminate them. We all have them. Now let's go back to the patient-doctor relation. At the end, what we want is we want to restore health. But when you go to the World Health Organization, to the definition, the definition includes also free from disorders that limit one's individual capacity in smiling and psychosocial well-being. This is very important. I mean, we're on a high risk. If I have a patient that suffers from a psychological disease, that I don't treat this disease with a mucogingival intervention. So we have to carefully evaluate. A nice study from Spain was evaluating the amount of claims or the influencing factors in oral and maxillofacial surgery. They showed in 1/3 implants had been included. The majority of these were placed 50% in clinics, 50% in private settings, and all of these procedures had been non-urgent, elective procedures with all the time in the world to discuss with the patient. Conclusions: treatment with the high aesthetic components generate more dissatisfaction in patients, and the results that do not fulfill the patient's expectations are likely to merit a claim. That means that unhappy patient mainly relies on a discrepancy between the expectations and between the outcome. And I can show you 9 cases. I treated 6 of them, or except these ones, by myself. The other ones were coming for retreatment. But now I ask this patient to value their happiness with the restorations from -3 to +3 as a best. This looked like this. So this patient here did not know why he comes, because his doctor sent him. And he said, look, you cannot see, so what we want to do. But this patient was my patient. And this patient was a nightmare patient. And I must say that I missed overconfident. I missed to explain this patient about the risk that we might lose a papilla, overconfident. There are many other biases in that. But you realize the complexity that we have to give this information to the patient. So this information transfer is not just talking with the patient. It is based on risk communication on all these aspects. You have a lot of literature data. How do we communicate risks? How do we communicate uncertainty? Because uncertainty can be based on, I don't know, because I did not read it, but it is also an uncertainty that you cannot know because it was simply not investigated. So the more you know, the more you can discuss and tell the patient, look, I know this has not been investigated. But there are also aspects on the side of the patient. Cognitive biases, a known perspective, a lack of participation. Patient maybe does not want to participate in the process. But this is our task, to finally try to evaluate where are the problems or where can I take the patients to participate in the process. And there are also patients that have no abilities to understand. Wolfhard and co-workers show this very nicely in prosthetic restored patients, that patients with high stanine values means with a tendency to a depression, you can do whatever you want. These people never will be satisfied. And this is also a risk that is on our side and that we should try to evaluate before we just run in and deliver something to the patient. If this is all that properly done, and this is a huge field, then we can say the goal is to have an evidence-based patient choice. This is different than informed consent. It means that the patient makes a choice. It's a democratic distribution of a treatment decision between patients, clinicians, or maybe between others. And the evidence helps you or gives you in this pipeline to give decision aids to this particular patient. The keyword that is, let's say, standing for, let's say, a transition for a healthcare economy based on the opinion of the clinician into an economy where the demand is based on an informed choice is named shared decision making. And there are many fields that already have proven that shared decision making is a very successful concept, especially for elective surgeries. I recommend all the clinicians to read one of the books, but I also recommend it to some of my patients, because what I would like to have is a patient that is health competent. I come to the conclusions. You know, I had the problems how to pack everything into this session. I think that the innovation consists of the pure fact that finally we talk on a congress about the non-technical skills, about decision-making, and about the importance of communication. They've shown, and this is not only my opinion, that in medicine, it's badly underestimated from general practitioners, but it's evident that the majority of adverse events are based on cognitive error and lack of communication. When I join in the congresses, lectures in the session, aesthetic complications, then you see a dramatic case where an implant has been placed in a completely wrong way. And this is followed by nice, glossy pictures, how the clinician was nicely restoring this technically. But this is wrong. Because what we should do is to avoid this adverse outcome. And to avoid, and this we have learned in aviation, requires that we don't say who did this, but that we say what happened here. And what happened here means to disassemble everything, to analyze it. Are they stress? Is there an influence of overconfidence? Is there an anchoring bias? There are so many things influencing there. And not only on the stages, we also should offer workshops around for critical thinking and decision making, or another workshop to improve the communication skills of clinicians as we are daily exposed to that. I thank you for your kind attendance.
Wow, Rino Burkhardt.
Yes, absolutely unbelievable lecture, and I think it was very interesting just to hear the opinion, how important is communication, and if we have any proofs how effective we are. So we have some questions to Rino for sure, and in the Q&A session we will continue with questions.
We have one more speaker to go, Florian.
Yeah, we come to our last lecture. It's Andrea Ricci, and he will talk about what, Chris?
Computer designed smiles, and I think without any delay, Andrea, the stage is yours.
Thank you.
Exactly, and while Andrea is walking over, let me remind you one more time that you can send in your questions here live in the room. Direct your mobile phone to app.eao.org. Click on the button Interaction. We already, as you said, have some questions coming in. So, Andrea, take it away.
Thank you very much for the kind introduction, and thank all of you for being here. Before I start the lecture, please allow me to thank my dear friend Irena for inviting me here, and to the whole scientific committee. what I will try to share with you is how the digital technology can help us clinically. I will share with you my story with Smile Designing from the start, really the basic, when we started to use the computer to smile designs, to perform the smile design, until the latest available technology. So, I would like to focus, after the incredible lectures at the beginning of the sessions, I would like to focus on feasible technology, which is available today, meaning that if I will be able to turn on a spark in your mind and wish you to try what I'm sharing with you here, you will be able to do it without huge investments. And this is something very important, because otherwise we see all the potential, and then you go in the clinic and you don't know how to apply that potential. So it means that it's useless. Okay? As Henry Ford was saying, the improvement, the technology, is only good if it is available for everybody. So, we all know about the facially driven treatment planning approach. It was described by Spear, Coyce, Shish, and many others. And this tells us that we shouldn't diagnose our patients from the teeth or from the intraoral situation, but we should address more comprehensively the situation, because we are lacking information in these photos. Where is the occlusal plane? Where is the incisal display? What about the gingival margins? What about the tooth proportions, shapes, position? If you don't see the face, you don't know where to put them. And so you're lacking information. So this is a case that I treated more than 15 years ago, and I was applying all the concepts that we all know. So impressions, in those days, all analogic, Facebook records, intraocclusal records, building up a wax-up, and design the case. The problem is that even if I did everything I learned very meticulously, what happened is the day I removed the upper restoration, I sent the patient to my father's office to perform the surgery. When the patient comes back, I reline the provisional. After trimming, everything looks nice on the articulator, everything is following the wax-up. Then the patient stands up. At the end of the day, hands say hello to me, and I look at him, and I see a canted occlusal plane. So what about this? What is the problem? I did everything. It is 28 years that I'm doing prosthodontics, so I know how to do it. Of course, I do mistakes, but I know how to do this. Nevertheless, I struggle still nowadays for solving these issues. And this is very time and cost consuming, because you have to go back and redo something that you missed before. And what was the problem? The horizontal plane of reference, the mounting in the articulator, the initial step. So I had to use another device. This is the Coyce face analyzer that I used in those days. I had to redo another wax-up, another day in the clinic, and then I was able to recapture the occlusal plane that is proper. But I had to use a different device. Time and cost, plus the management of the patient. How do the patient see you that you have to redo the same thing that you did the previous appointment? So we needed a better starting point. And again, we have to go back to the basics. I mean, this is basic, really basic. Computer stuck, which makes me feel very good. But what we need is basically 3 lines. And these 3 lines, we learned them when we were in the undergrad school and we were working with the wax trim. We need to transfer these concepts to the virtual Facebook and define incisal length, midline, and horizontal aesthetic plane. After that, you set the anterior teeth. If you want to learn aesthetics, do a complete denture. And you will immediately see if you're able to provide aesthetics. I am a little bit more, my personal statistics, slightly different from José and Pablo, because I spend a lot of time in planning. Either it is in the lab, when I do analogic work, I have my own lab in the office, or in the computer nowadays. But the execution should be very, very minimal. When you build a house, as was mentioned, architect comes before the engineer. First, you want to know where you want to go, what you want to design, what you want to rebuild. Then the engineer comes and make the plan possible, feasible. And then the craftsman starts to work. And this is exactly the same. We have to design before planning the sequence and then execute. So we know that two of the major difficulties in prosthodontics is to record the inter-arch relationship for function and to define the horizontal plane for aesthetics. So how did we, years ago, solve the problem? The problem is, if you have a symmetric patient, everything you do when you record the faceball is fine. You don't insert any error in the process because the faceball will be parallel to the horizon. But when you have an asymmetric patient, things are different. So many authors suggested to go and play around with the faceball, which is very uncomfortable, and you run the risk of inserting a huge amount of problem. Imagine, this is not only for prosthodontics, because if you're planning a surgery and you didn't record this, the occlusal plane will be canted. All the implant positioning will be canted. If you do an Invisalign procedure, all the outcome will be canted. So this is the basic of designing. Okay? So my personal statistics is that, for example, very few people, I would say around 50%, which is very few for me, the interpupillary line is not reliable. 66% in these 3 patients, 2 patients out of 3. 2 patients out of 3. The bipupillary line is not a reliable reference. So, what to do? What to do here? We need to plan differently. So, more than 10 years ago, we started analyzing the face and use a virtual articulator. So basically, we start the design of the aesthetics on a 2D dimension, and you can do this in your own computer. You don't need any software to do this. All this is done with Keynote or PowerPoint. This is how we used to work. So we rotate, and we define the occlusal plane of reference. So we don't follow the eyes. We don't follow the nose. More than 50% of patients, the nose is not a reference. And guess what? What are the 2 parts that are most misleading in aligning the faceball? The eyes and the nose. So it's not a good reference. So we need to calibrate this. So Christian and others, defined a protocol that by using Keynote or PowerPoint, or nowadays some apps, you can transfer all these informations from the face photo to the intraoral photo. And then transfer the 3 lines, midline, incisor length, and occlusal plane. You want to add the smile line, the orange line, fine. But after this, you can define, as I said, midline, incisor length, occlusal plane, and design. So let's take a look at a case, one of the first one that I did with Christian. So just doing this protocol, just utilizing the photos, we were able to align the extraoral. This was another type of procedure that I will show you in a little while. And I was able to provide in 2-dimension information to the technician. So I was writing numbers on photos after calibrating the digital ruler on a facial point of view and also on an occlusal point of view. So I could provide measures. But what was the problem here? The problem here is that I still need the technician to work on the bench and translate all the information from the screen to the 3D world, which is in those days was analogic. Okay? So the problem is that we were bound to the technician. And by doing this, we were able to provide nice restorations, monolithic restorations, predictable restoration. The limitation of this is, as I see here, the dental technician interpretation. The clinician is not involved in the wax-up, and it is not possible to copy and paste our treatment. So nowadays, we developed. So what are the next steps? The next steps is either to use a 2D photo and try to merge it with the 3D world without having to go through the wax-up, or the 3D world. Let's take a look at the first option. Now here, I have a video that I did not edit. And here I share with you, let me see if I can manage this from here. And basically, I can't control I cannot control the screen, the video. I cannot go back and forth. But anyway, what I do here is I do my smile design on the computer following the face. This is done with a software that utilizes a 2D photo that I'm showing here, and I align the 2D photo to the STL digitally recorded with the intraoral scanner. So now you see here, remember before I was aligning a 2D photo over the face photo in order to align the intraoral photo correctly. Now here, I am aligning the STL. So now I can transfer the aesthetic outcome into the 3D software that I will use to plan and to design digitally the wax-up. Okay, it takes a while, but you see that is very, very precise and very, very simple. Then you cut, and you start designing the outcome. So, to take a quick look on a patient that desires a new smile. So, the key point here is who should design the case? Who is the architect of the case? You can record the scan, but here is the point. And the point is, to me, it is the clinician that should drive the treatment planning and should design the case by himself. Because this provides you so many elements. You know what the patient desires. And in this video, it is 15 minutes. I was able to design a wax-up from canine to canine, upper and lower, in 15 minutes. So you don't need to be a talent in designing and doing the wax-up, but you can still plan everything by yourself. So I was able to prepare the mock-up, cut and paste, final minor touches, and provide a mock-up as it has been shown by previous speakers. Then the outcome, it is quite simple because we all know how to design preps, how to do veneers, and this is a very challenging case that I solve this way with restorations. Now, what is the limitation of this system utilizing a 2D photo and the intraoral STL? Because you are dependent on the 2D photo. If you do not have a nice photo, you cannot plan it. You cannot utilize that in order to have a nice smile design. So, what about the 3D scans, the face scans? I have been trying many systems, from the most expensive to the cheapest one. Okay? All of them has advantages and disadvantages. Whether it is dynamic recording, like a video, it is a static recording. But the point is that we need to take advantage of the face scan because we avoid the need of a perfect photo. And what I would like to share with you is, for example, something that is the simplest version of the highest technology that we have seen this morning before the break. So basically, it's a new face scan software that I'm still trying. You take approximately 150 photos with the phone, and very economically, you can have a 3D scan, which is very accurate. And here, what you can do is align to the face, scan the intraoral STL. And this allows me to design the case. I have all the function needs in my head. I have all the discussions I had with the patient. I know what I want. So basically, in this situation, I will, which is the tricky part, align the photo, the scan, to the face, to the STL. And there are several softwares, they do different ways. Still, I'm testing the best one. In this case, what I'm using is exactly the same principle as before. So basically, going and superimposing the two images, the two informations, the STL and the OBJ file, and start aligning them together. I want to go farther, but I cannot see the cursor because it's cut. So, what are the limitations of this system, of the face scans? First of all, the problem is to align the face to the intraoral, as it was said. So somebody suggests scan bodies or soft tissue. For example, when you have, let me rephrase it. The limitation of this is, first of all, the accuracy. You have to have a nice, precise scan, unless you have a device that costs, I don't know how much, as it has been shown before. But with cheap systems, even the ones not so cheap, the alignment is the weak point. Second, the face, the tissue mobility, the expressions. If the patient is very dynamic in the movements and have very active muscles, then it's very difficult because when you take a face scan, when you smile big and when you are at rest, for some people, the face references are completely different, so you cannot align them together. And the cost of the device. But why computer designing is a need? Because instead of throwing the responsibility to the technician, which of course is part of the designing, you can design the case yourself. You start with the end in mind. So you define the incisor length, the occlusal plane, the midline, and the design if you want, immediately after the first visit. You reverse engineer the case. So you start from the end and you go backward. And this is only possible with the digital planning. Communication tool, the best way, and I'm sure Rino agrees, the best way to communicate with the patient is by visual communication. Show them what you're talking about. And plus, as it has been shown by Pablo and Jota, you can control very well your treatments. Everyone wants to be successful until they see what it actually takes. And all you have seen and you will see in these days, if you want to apply that, it's only a matter of mindset. Just try. Just go for it. You will have problems, you will do mistakes, but it's the only way you will expand your vision and your abilities. Thank you very much to all of you. Thank you, Irena, and look forward for the discussion.
Thank you. Thank you, Andrea, Ricci. Please come join us. We have a few minutes left to take some of your audience questions and to also reflect together with our chairs. Chris, Florian, please take the floor.
Yes, it was a really very interesting session, thank you, and very interesting lectures. But in the same time, I have one question which addresses all of you. Because in your presentation, José and Pablo, you had 70 to 30% ratio planning and execution. Andrea, 80 to 20. In the same time from Rino, I would like just to hear what is your opinion, how much we should spend, which is not highlighted efficiently for communication. So first of all, from your side, 70 to 30, how you manage?
So I'll be completely honest with you. We had 80-20 last night, and we kind of changed it to 70-30 to be a bit more on the safe side. The reality, we haven't measured it. It's a way of kind of analyzing how much we're devoting to planning, which is a lot, a great deal. Much more than we used to, I think, and definitely that reduces the time that we're spending in the chair. That's a given. I think that, that's the approach moving forward.
But I think, Chris, you want to know how much in that equation is for communication specifically.
Right, okay. I believe probably communication goes all along. I mean, I don't think communication ever stops. So I would actually say that the whole time is communicating. We're communicating all the time. I mean, we communicate with the whole team, with the patient. We make them, as Rino was saying, we make them part of the decision-making process throughout, which at the end of the day, I think is mandatory for even to protect ourselves of what could potentially happen if anything go wrong. So communication, I think, goes pretty much throughout. Do you agree?
Yeah, we spend a lot of time in the first visit nowadays, so with the digital, the intraoral scanning, we really take at least 1 hour, 1 hour and a half to acquire all information, and we really, as José showed in the lecture, we try to do this dental experience with the patient, having the biology and everything in mind, to share and communicate a lot. So we really believe that the first visit and this initial connection with the patient is very important to then later on take the information and share with the different specialists.
But in the same time, the time is the money. How you manage in a daily practice?
Well, I agree definitely that the soft skills, as compared to the hard skills, which is the communication, goes way before the patient walks into the office, and it ends way after the treatment is completed. Because even to follow up the patient and control the patient and manage the after treatment requires a great time of communication. Communication is soft skills are used 100% of the time, definitely. I mean, I receive messages from my patients every day, and that is communication, that is critical. And I would say also, on their eyes, the most important. So time is money, yes. Probably that's why I'm not that rich, but I like to relate with patients and know that we are in rapport. The rapport with patient goes up and down. It's very low when they walk in for the first time. You can manage it with the communication before, but then it increases because of the personality, because the charisma can increase. But then when you do the surgery and you provide pain or sutures or graft, the rapport goes down. And so you have to play around with soft skills 100% of the time.
Rino, what is your opinion?
Basically, I think we should differentiate between treatment planning time overall and the time that we really spend face-to-face with the patient. Honestly, I would be careful from my perspective to give absolute numbers. I just had a patient that my colleague in the clinic had last week. This is an elderly man that was on one side, a broken bridge, and that had to be redone with implants. He had a full restoration already. He was very happy. A restoration that was awful from many points of view. Awful means aesthetic perception and zirconia reconstruction. He went to the lab technician, Walter Gebhardt, and Walter was done in 5 minutes. Because the patient came in and said, look, you don't have to discuss, it's this what I want. So I think it depends simply on the patient individually. With some you have to spend more time,
Yes.
and with the others maybe you have to spend less time.
Yes.
There was a quick practical question, if I may, Florian. When you shared your whole workflow, and you also now say, Pablo, we spend 1.5 hours scanning, photographing, doing all this stuff. Do you do that with every patient, with each case, regardless the complexity?
Basically, as we shown in the lecture, what we are doing as a first visit, we take pictures, videos, intraoral scan, and x-rays. That's the basics. And this is what's done with the equipment that we have in the office, with assistants. And then later we analyze and we listen to the patient. But we have already all this information that later on we can share, diagnose, sit again with the patient, and do the treatment plan. But yes,
So standard, every
standard
patient,
for every
regardless what they walk in with.
That doesn't mean we're both doing it or either of us is doing it. There's a setup of a team that is actually taking the patient through this process in a nice way, and then that gets presented, and we start talking and discussing about it.
Yeah, also my question goes into that direction. When you talk about 80 and 20%, is that the time that is invested from the whole team, or this is your personal time you're investing?
In my case, or in our case, I think these are numbers that I just brought up. There's no scientific evidence of what I'm saying. I'm just saying, or what we're trying to show is that we're spending, as I said before, a lot of the time planning, and that reduces the actual treatment time per se, because we've built up all those steps so that everything falls nicely into place. Whether it's 80 or 75 or 82, I'm not really sure, but that definitely includes the whole team. Everybody works together in that planning phase.
In the same time, this is a session about new technologies. So we know that to implement these new technologies, it requires finances, investments, and time. What would be your suggestions to colleagues who didn't start yet with digital? Is it worth it, and how to do it in the most effective way?
Yeah, where to start first,
Where to
right?
start first?
So,
Should I go?
Yes.
Well, on my opinion, the entry level is an intraoral scanner. So that is mandatory, because otherwise, you know, to scan the impression makes it, doesn't make sense. So the intraoral scanner is something that is the first step. Then I would go to the 3D printer, which opens a huge amount of discussion, you know, because we still are learning, plus the devices are all different, the resins are all different, so there is a lot that we have still to learn. The point is, it's not if it is needed to walk and step into the digital world, but it's when. The sooner you start, the sooner is the learning curve starting, so you will be able to get ready, because it's the matter of time, and we have to go through there.
But you are more about hardware, but what about software?
Software, there are
There's a lot of audience questions about if you can drop some apps, like which one do you use to share the planning with your patients? Which app do you use to do the facial scanning with the phone?
It is very, very, very expensive, because it costs €7 per month.
Can you drop the name of the app or not? Or maybe share with the audience later on?
It is an app available on the App Store and on Google Play, and it is called Metascan. So basically, it's very simple. Records 50 photos, you upload, and 15 minutes afterwards, you receive the file and the video. So it is probably the next step of other apps that use the mobile phones, and it is promising. They are not perfect, but it is promising, and the cost involved is very, very achievable. I tried also very expensive machines, and I had issues anyway. So, you know, I wouldn't like to suggest to buy.
You told us it needs to be feasible and accessible, otherwise it's no use. We are in our final minutes of our session, so I'd like your question to be answered by Rino and Pablo and José as well. Chris says, where to start? What is the starting point?
I mean, it's a good question. Maybe one should start or ask oneself, what is the incentive that I start with? And then you come to the starting point. I mean, it can be somebody wants a procedure to remain competitive in the environment.
So answer that for yourself, Rino. What was your starting point?
We have, let's say, print, also the scanning of the. I'm a periodontist, so I don't use this technology so much. But yes, we use scanners, and the prosthodontist, she does not use a face scanner. This I know.
Final words, gentlemen.
I think that, you know, as long as we know biology and function and we know the analogic way of doing things, we can then start implementing the technology in our practice. I mean, the basic fundamentals need to still be what they are and what they've always been. Intraoral scan, for sure, that would be also my first guess, to start with that. And through that, you start to see what is it that you need for manufacturing. Obviously, 3D printing is very cheap and gives you a very broad possibility. But I think that's kind of like the way I would build up to technology.
Good.
Pablo?
I also think that it's very important when we want to jump into digital to train our team, because we go very excited with these technologies. When we go to the congresses, we see lectures, but we need to get the team to be part of this new adventure into the digital world, so everything will work much better and with a better success in the daily practice.
Agreed.
Great message, Pablo, because it gives me a chance to actually invite everyone in the room to make sure that your team is also joining the digital side of this Congress from wherever they are. So at least when you come back to the office on Monday, you have stuff to share. For example, this session, they've already watched it, and you can then start the discussion. Chris, Florian, thank you very much for sharing this great session. Good luck.
you.
I think there's people in the room who would like to discuss much more. There's many more questions, so we have the opportunity to do that here as well. Thank you for the interesting session, and thank you for watching online. I really hope this will help to further improve the relationships with your patients.